Welcome everyone to this webinar. It's a really interesting topic, something I'm sure that you've had many conversations within your own services. So welcome to a webinar from MS Academy on ageing and MS. I just want to say a big thank you to our sponsors, Novartis Pharmaceuticals UK Limited. The first session is the webinar, which is designed and delivered by the MS Academy and sponsored by Novartis Pharmaceuticals. The sponsor has had no input into the educational content or organisation of the session. The second session is a promotional satellite symposium that is organised and funded by Novartis. The satellite symposium is for UK healthcare professionals only. So let me introduce you to the speakers for both. For this session from MS Academy on ageing and MS, we have an absolute pleasure to introduce you to three faces who I'm sure are very familiar. We have Dr. Wallace Brownlee, who's a consultant neurologist working at the National Hospital in London. We have Michelle Davis, who is the MS specialist practitioner and service lead for Dorset MS Service, and Rachel Dorsey-Campbell, who is a senior lead pharmacist for neurosciences at Imperial College London. So welcome and thank you for joining us. And for the symposium, James Farley, who is a consultant working at Charing Cross Hospital, will also be joining us alongside Dr. Brownlee. So here are their disclosures. And just to quickly go through the objectives for the session, which are we've got a really interesting, wide and varied session. So initially, Wallace will kick off with looking at an impact of ageing on MS disease course and the impact of comorbidities in the older person with multiple sclerosis. And then Michelle will go through looking at kind of understanding of the comprehensive assessment in the older person with MS. And then Ray will finish with looking at an overview of disease-modifying therapies in the older patient. And then if you do have any questions, please obviously put them in and we will go through them. I thought it would be of interest to know that there were over 200 that signed up. And we've had such a really interesting, wide, varied group of interested parties in this webinar. So, thank you very much for your interest and I hope you enjoy this session. Just to let you know, I am standing in for Julie, who was due to chair, but she was unable to take on this session for personal reasons. So the timeline that we will be working to is the MS Academy session will be 45 minutes. We'll then have a really short break and we'll then head into the symposium, at which point I'll hand over to Wallace. So as I've already mentioned, please do put, if you have any questions that come up during any of the sessions, please do put the questions in and we'll aim to answer them at the end. If we don't, for whatever reason, if we're inundated with questions, then we'll try and maybe address some of those on the website with the recording. So it's with absolute pleasure I'll hand over to Wallace for the first session. Thanks, Wallace.
That's great. Thank you very much, Ruth. So I'm going to sort of set the scene for issues related to aging and comorbidities and how they relate to MS disease course and some considerations for our management. So those are my disclosures. So kicking off with issues related to aging first. We've got an aging population of people with MS. So in the United States, which is the most recent data I could find, over half of people living with MS are now over the age of 55. And for those of us who got into the field of MS because they like dealing with kind of young adults who are in their 20s or 30s, actually, this may be not such great news, but I think this reflects what we see in the general population. We've got an aging population that's relevant to people with MS. And actually, it's interesting to note that the age at which people with MS are getting diagnosed is becoming older. So when you read textbooks or review articles, often age over the age of 50 is considered to be late onset MS. Thankfully, I'm still in the early onset or standard onset MS range because I'm under the age of 50, but 50 doesn't feel old particularly, but for a diagnosis of MS, typically late onset MS over the age of 50 is what's being considered, or very late onset after the age of 60. And in the right-hand panel here, you can see the study from Italy showing that in epochs from 1991 to 2021, actually there's been a shift to the right in the average age at diagnosis, and an increasing number of women, particularly with relapsing MS, being diagnosed after the age of 50. Now, age has a profound impact on MS disease course. I think this is relevant for all the discussions moving forward. So features of aging in the context of MS are falling relapse rates. So every year that goes past, the chances of having a relapse for an untreated patient goes down. Fewer new active lesions on MRI, and that's shown in the study on the right-hand side here. So the chances of finding a gadolinium-enhancing lesion on MRI really starts to go down, particularly after the age of 50. Patients who are older, though, when they do have a relapse, they're much less likely to recover. And I think that's really important when it comes to selecting disease-modifying therapies. And as we're aware, with aging, there's an increased risk of a progressive disease course. And when MS does start over the age of 50, and particularly over the age of 50, primary progressive MS is much more common. Now, what are the factors that drive these differences related to aging? And for more information, there's a really excellent review in Lancet Neurology from 2002 from Jen Graves, who's at the University of California, San Diego. She considers herself to be a lifetime MS specialist. She's interested in pediatric MS and older people with MS, so she is interested in managing people from the whole range, and I guess sees in her clinic the impact of aging. But some of the key things here that I'm going to discuss in the next few slides are issues related to changes in the immune system as we get older, so-called immunosenescence, reproductive aging, and comorbidities. So somatic aging and immunosenescence. So somatic aging is just related to our the changes that occur in our body as we get older, and I think we can all appreciate that our body changes with time. And a marker of this is the telomeres. So they're the bits hanging off the end of our chromosomes that get shorter as we get older, and that's something that we can measure in blood. The shorter our telomeres, or the shorter the telomeres of people with MS, the more likely they are to have disability, progressive disease course, and lower brain volume. And so that shows that the aging process is something that's relevant to MS disease course. Now, the mechanisms for this include inflammaging. So there's changes in the immune system as we age that lead to a chronic low-grade state of inflammation. And that may affect MS disease course, for example, by activation of microglia in the brain with those slowly expanding lesions that are like embers at the edge of a fire that are slowly damaging the white matter and the axons around it, and the changes we see in normal appearing white matter at autopsy. The second change related to aging that's relevant here is this process of immunosenescence, where immune function and our response to pathogens and infection changes as we get older. And what I often say to patients is, this is why your immune system changes as you get older, and that's bad news on the one hand, because people tend to be more vulnerable to infections, and just think of a person in their 70s and how they respond to, say, a bladder infection versus, say, someone in their 20s. But actually, sometimes this can be good news for people with autoimmune diseases, because if your immune system gets more crappy as you get older, that can be a good thing if you've got autoimmunity. So we see reduced lymphocyte function, and that may be why we see fewer relapses and new lesions on MRI as people age. Now, reproductive aging is, of course, important as well, and estrogen has a neuroprotective effect on the brain in women, but also in men, because in the brain, estrogen is converted, testosterone rather, is converted to estrogen via aromatase. And changes in sex hormones that occur during the lifespan, the slow gradual change in sex hormones in men beginning around the age of 30, and the abrupt change in sex hormones that occurs in women around the time of menopause has an impact on aging processes, and is relevant to MS, because most studies show us that MS is worse in men than women, and men, of course, lose their sex hormone protection more slowly, but that begins earlier. And women, many studies have shown this transition point around the time of menopause for worsening disability. And some other studies that have demonstrated this in women, anti-Müllerian hormone levels, which are a marker of ovarian reserve, correlate with grey matter atrophy in the brains of women with MS. Now, just a quick case history just to break things up here. So I've got a 69-year-old woman. She was diagnosed with MS in 1984 after an attack of optic neuritis, followed numbness in the right arm. She had a lumbar puncture, which confirmed the diagnosis. And her last relapse was in 2006 when she took steroids. And she got re-referred to the clinic. She'd not been seen for many years, with a 1-year history of a limp affecting the right leg and difficulty climbing stairs. And she'd never had an MRI scan, so one of those had been arranged before she came to see me, and that confirmed changes consistent with MS. And the question for me was, was she eligible for DMTs? You know, should she be considered for siponimod for presumed secondary progressive MS? And I examined her, and I found some changes in the right leg that could be relevant to, the left leg, which led to this. I don't order this test very often, at least not these days, but I ordered a hip x-ray for her, and she's got advanced osteoarthritis here, which I think was the cause for her worsening of her walking. And so this brings us to the term, a new term in the lexicon on the next slide. We don't need any more acronyms in MS, but I'm going to give you one more, which is PIMS, progression independent of MS. And so not all worsening is MS related. It might be due to musculoskeletal disorders, a second neurological disorder, menopause, mental health, or healthy aging. Now, I've been optimistic in how much I can cover, but I'm just going to whip through comorbidities and just say that comorbidities in MS can either be time limited, so an intercurrent infection. They can be recurrent, i.e. recurrent UTIs, or recurrent fragility fractures, or chronic, like COPD. And the burden of comorbidities among people with MS increases with age. So in older people over the age of 60, many comorbidities, excluding mental health problems, are much more common as we get older. And comorbidities not only are more common with older age, but more common in females, more common in people with higher physical disability, and at least in the general population, ethnicity affects comorbidity burden. And comorbidities have a big impact, and relapse rates, physical disability, cognitive impairment, quality of life, employment, mortality are all impacted by comorbidity burden in people with MS. And there are really three, and I'm not going to go through each individual slide to save time here, but there's really three to be thinking about that I think are important and that we can modify. The first is cardiovascular disease. You know, we've got to think, when was the last time someone had their blood pressure checked, their cholesterol? The second is infection. And the infections that I guess are most relevant in our population are UTIs, but we need to be thinking about protecting our patients from infection, for example, shingles vaccination or pneumococcal vaccination as people get older. And the third is osteoporosis. And I think this is something we're really bad at screening for. And tools for estimating osteoporosis are not good in people with MS. Pardon me. So I think I've shown you that age has an impact on MS disease course. The mechanisms are varied, and comorbidities can influence both disease activity and progression. So back over to you, Ruth.
Thanks, Wallace. Now, my absolute pleasure to introduce Michelle Davis, who works down in Dorset and mentioned before. She's going to go through the comprehensive assessment in the older person with MS. Over to you, Michelle.
Hi, thank you. Can you hear me all right? Oh, great.
Yep.
That's good news. So thank you to the MS Academy for inviting me to talk about this assessment in older people with MS. A bit like Wallace, it's going to be a bit of a whistle-stop tour because I've been a bit over-ambitious with my slides too. So here are my disclosures. And when I first started thinking about comprehensive assessment, I was first asked to do this. There were a whole ream of things that came to mind, but actually to go through all of these will take more than one session. So we've narrowed it down a bit. Next slide, please. So when we think about it, all or most areas covered with a younger person with MS should still be considered with an older person with MS, and assessment should of course be tailored to that individual. But there are some areas which may need to be focused on more in the older person. Next slide, please. So I've kind of grouped these into these areas. Next slide, please. Okay, so comorbidities, Wallace has talked about this, so I'm not going to discuss it in any detail, but We know comorbidities have a significant impact on people with MS, and the more conditions people have, the more medication they have. And I know Rachel will probably touch on this in her talk as well. So again, I'm not going to talk too much about this, but medications can obviously be useful for those other conditions, but they can cause problems overall and with MS impairment. And we know there are medications that do negatively impact people with MS. And I've given the example of anticholinergics there. Next slide, please. So I don't know how many of you have actually considered frailty in MS. And I think, you know, as a physio by background, I think probably I've thought about frailty a bit more. But frailty can be defined as an age-related syndrome, as is that top description there. And anybody can get it as they get older. Age UK describe it as overall resilience and how this relates to somebody being able to bounce back from illness or injury. And at the bottom there, you've got a definition or a statement basically saying that anybody can have frailty, but people with other conditions, it may well be masked, and therefore we don't necessarily pick up on it. So I think it's worth us thinking a little bit more about frailty with our patients. Next slide, please. And when you look at the signs and symptoms of frailty, you can see why we may not notice it with our people with MS, because a lot of those signs and symptoms are things that people may get with MS or could be confused with things that people do get from their MS. Next slide, please. So when I started looking at frailty, these 9 things really are the things that kind of pop out of things that probably we need to be considering. And this is partly to identify whether we think someone is frail or are maybe entering that cycle of frailty, but are also really important. I think this is something we can all take away. These are things that maybe we ought to be thinking about a lot earlier in people's journey and how it can impact them when they're older. So that's my statement on the left. Think proactively as well as reactively on all these things. And if we move on to the next slide, we will kind of see how those feed in. So this is a cycle of frailty. And if we start on the left there, we can see how reduced activity can feed into a cycle of reduced nutrition, weight loss, sarcopenia, reducing metabolic rate, and how in turn that can lead to reduced energy, exhaustion, muscle strength. And then that bit at the bottom there, muscle strength, in turn goes into its own cycle of impaired balance, falls and injury, immobilization. And Wallace has already talked about bone health. And actually we know that people with MS have got a higher risk of osteoporosis. There's a higher incidence of osteoporosis. So it's really important to manage that bone health and consider falls risk to help reduce fracture, because we all know if someone is immobilized with MS from fracture or anything else, the devastating effect it can have on their activities of daily living, their walking and participation. And then it mentions strength. That isn't just about leg strength, that's also about core strength, grip strength, and actually in the toolkit to look at frailty, actually grip strength is used as the marker of strength in that incidence. So all of those things will have an impact on walking speed, disability and dependency, which then takes us back to activity. And that activity could be anything. It could be things around the home, but it's also about being able to get out, about and participate in normal life. Next slide, please. So moving on to the next part, which is mental well-being and ageing. So here are some stats. So they're quite shocking, really, aren't they? 1 in 4 older people live with a mental health condition. You know, around a quarter over 65 will experience depression. 40% of care home people live with depression. Carers, 30% of older carers experience depression. And then it talks interestingly for us about people who've been bereaved. So a lot of people as they get older, that is something that people deal with more in older life, obviously, than younger years. And this article that I read was talking about living with long-term conditions actually significantly increasing the incidence of and can exacerbate mental health conditions, which I don't think we would find a surprise. Next slide, please. So which area should we focus on? So obviously depression and anxiety. Dementia, the incidence obviously of dementia goes up as people get older, and we may not notice that as much because of cognitive impairment, but it is important for us to consider those conditions that people are living with alongside MS. So is it cognition, is it dementia? And I think we should be alert to those things. And also if we're seeing people thinking about the mental health of their carers. Next slide, please. And tied in with anxiety and depression are loneliness and social isolation. So they're tied up together, but they are quite different things. So loneliness is the negative emotion. It's that perceived gap between the quality and quantity of relationships that we have and those that we want. And you can actually be surrounded by people and be lonely, and you can actually be quite isolated and not be lonely. So it's important that we ask those questions. Whereas social isolation is the quality and the quantity of social relationships and contacts that people have with others, with groups and communities. And older people are especially vulnerable to loneliness and social isolation, and certainly our people who have got more disability will also fall into that, whether they're older or not. Social isolation is a factor known in worsened health outcomes, and earlier mortality. So, these are things we should be talking about. Barriers to social participation. So we've talked about disability, but if we can find ways of actually enabling people to access groups, whether it's day centres or other groups that they can get to, then we should be considering that as part of our assessments and plans. Next slide, please. And these are known modifiable factors for healthy aging. So staying active and getting enough exercise, and that's not just cardiovascular exercise, that's strength, balance, flexibility, getting enough good quality sleep, not smoking, making healthy food choices, limiting alcohol intake, and like we've just talked about, having meaningful relationships. Now this isn't just for people with MS, obviously this is for the general population, but it's even more important for our people with MS. And on the right there, it's managing those comorbidities and proactively managing health. So managing MS symptoms well, managing other health conditions well and recognising them, taking recommended medication, having recommended screening. Wallace has talked about vaccinations, and stress is another one that's mentioned as part of that. Next slide, please. And Wallace has already talked about Jennifer Graves' work, and it's worth her work's really worth a read. But there are young old people and old young people. So when we think old age starts, isn't actually necessarily right. So it's actually timing your interventions and your assessments according to how someone's presenting. So you may have somebody in their 40s who has aged considerably and biologically is probably a lot older. But the good news is that you can actually alter your biological age by changing some of those modifiable factors. So think about those things that we just talked about on that previous slide, because people can actually change their biological age. Next slide. So that's a whistle-stop tour through assessment. So hopefully it's given you a few hints and tips, but in summary, the assessment template is the same, but more focused in some areas. Think proactive, so don't wait for someone to become old. Think about things that need to be done earlier. Think about and manage comorbidities and polypharmacy. I think that cycle of frailty is really useful in how things can spiral and the knock-on effect that one thing can have with another. So it's worth considering all of those aspects. I really hone in now a lot more on the mental health of people, and especially those with older people, and really think about that social isolation and loneliness. And we've just talked about the modifiable factors and how we should all be thinking about them for ourselves, but also for our patients. And like just to end, think biological age rather than birthdays. Thank you.
Thanks, Michelle. That was a whistle-stop tour through a whole lot of information. I think it wonderfully highlights how important the MS multidisciplinary team is. We bring so many different skills and knowledge and experience to the team and to the people that we look after. So, absolute pleasure to hand over to Rachel Dorsey-Campbell, who will go through a kind of probably a similar whistle-stop tour of the overview of disease-modifying therapies in the older patient. Thanks, Ray.
Thank you, Ruth. Hello, everybody. So yeah, I mean, as has been mentioned by Michelle, there beautifully outlined the complexity of looking after any MS patient, and then it's, you know, the added layers of complexity for an older patient with MS, and it's not about the drugs, and we really need to sort of focus our services, you know, wider than just the therapies. But having said that, I am here just to talk about the drug therapy, so we're just going to concentrate on that for the next 5 minutes or so. Next slide, please, Ruth. So many of you will be familiar with this slide, which was a meta-analysis of MS trials that looked at the effect of drugs on the effect of age on the effectiveness of drugs, essentially showing that the DMTs, if you take it at its sort of bluntest form, stop working after 53, apparently. So that puts some of us very much on the cusp of being considered old. But I mean, as Michelle has just said, age is not just about a number. And as we also know, a lot of older patients are excluded from clinical trials. So the sort of effectiveness of DMTs in older age is really about real world evidence rather than trial evidence. But there is this signal that the drugs do not work so well in older people. Next slide, please. So as well as thinking about how effective the DMTs are in older people, we also need to think about how safe they are. So whilst we might have some question marks about whether a drug is working so well in an older person who's having less relapses and less disease activity, we also need to think about, is it safe to continue to prescribe DMTs in an older population? And this is just some data that shows that the longer you're on a treatment, there is an increased risk of developing infection. And we know that, particularly with some of our more highly efficacious therapies. We know, that we're looking at increased incidence of a hypogammaglobulinemia maybe, or just increased infection rate with certain drugs. And so infections are a serious consideration in an older person. And then the data on the right just breaks that down further in terms of, it's not just about the age, it's also about how disabled a person is by their disease. And you can see that the rate of infection in the progressive population is higher, and also in patients with an EDSS above 6. As patients got older, infections were higher. Next slide, please. And as well as infection, one of the concerns that we often talk about with patients, or patients often talk to us about, is the risk of malignancy. And we're always worried about long-term immunosuppression and what that means for people in terms of malignancy. And the data is very mixed. If you start to look at sort of the reports of malignancies and DMTs, you'll find a lot of noise in the data in terms of what's what the real increased risk is or isn't. This particular study looked at 45 trials and showed that there was an increasing risk of malignancies in older patients defined as over 40, particularly treated with cell-depleting agents. So, older patients, are more at risk of malignancy anyway. As we live longer, we are more likely to develop them, and is having someone on a long-term treatment contributing to that? Next slide, please. So given that they might be more at risk of infection and possibly malignancies in older age, and the drugs might not be working so well, should we just stop drugs in older people? And this was the first study that looked at that. There have been others since. So there's another one I think that's finished, and a couple more that are ongoing, that looking at a treatment discontinuation. And this study was a randomized non-inferiority study of patients over 55 who'd been on a DMT for at least 5 years, and had no disease activity in terms of no relapses in those 5 years, and no new MRI lesions in the previous 3 years. This, as I said, was the first trial that had looked at discontinuing treatment. And although stopping a DMT was not inferior to continuing, it didn't reach its statistical threshold. And as I said, there's other studies that are going on to try and repeat some of this work. But I think essentially there is mixed data when you look at it as to what the outcomes are in stopping DMTs in older people. And the guidelines that we have are not particularly helpful around this. There's no specific guidance that tells us when we should stop a drug, other than commissioning guidelines, which give us criteria based on disease progression and EDSS, but not particularly around age. Next slide, please. So if we were thinking of discontinuing treatment in older patients, the things we have to think about, there's more to think about, should I say, if we've got somebody on more highly effective therapy, because we know that there are consequences to stopping some of the treatments that we use. So for instance, S1P modulators, we know have a well-defined risk of rebound disease on stopping. So it might be that we want to switch someone to an alternative agent rather than just stopping them completely if they're on an S1P, and consider bridging them with something like cladribine or an anti-CD20 therapy. Similarly, natalizumab or integrin inhibitors are known to have rebound disease. And again, you might want to offer somebody something to bridge them when you stop a treatment if they're an older patient. But then the anti-CD20 therapies, we don't have that specific risk of rebound disease. And it is possible maybe that we should just be giving those infusions, such as ocrelizumab, a bit less often, increasing the interval between infusions rather than just a hard stop on the drug. So we have some options when we're sort of trying to back away from treatment. And I think that's it's useful to think about that. So Michelle's mentioned polypharmacy. I'm not going to spend too much time going on it, but it is something else to think about. So when we're having these conversations, when often in our MDT, when we're talking about whether it's the right time to stop a treatment, there's often a lot of reluctance because of the anxiety of creating a problem by then having a relapse or disease activity because we've stopped a drug. Often age will come into that conversation because, the older a patient is, the more at risk they may be of things like infection and malignancies and other things that we might be worried about. But equally, the older they are, the more likely they are also to be on other treatments and have other comorbidities. And this particular paper was showing that people with MS are at risk from negative outcomes from polypharmacy, and that we should be considering deprescribing. And this is not just DMTs now. This is, as Michelle alluded to, there's lots of other therapies that we're giving our MS patients, particularly neuropathic pain and spasticity meds, anticholinergics, things like that we should think about stopping. Polypharmacy, the information on the right is not from the paper on the left, but polypharmacy is common across adults, with 10 to 15% of adults 40 to 65 being on more than 5 drugs, which is how that's defined. Polypharmacy is more than 5 medicines. But as you get over 65, that becomes a third of that group of patients that are on more than 5 therapies. And that, the data tells us, is increasing over time, that people are getting put on more and more treatments. So it's really incumbent on us, I think, as healthcare professionals, to think about what drugs should be stopped and not just what drugs should we start in patients. Next slide, please. So what do we do with our older population? As Wallace told us, our population, our MS population is getting older. They're being diagnosed later. They're an aging group. As Michelle's told us, there's lots to think about. When we're assessing these patients, it's not just about their drug therapy. There's a lot to think about as well as in terms of other things we could be doing for them. But we certainly need to be treating the individual patient and not just their age, because as Michelle said, there are old young people and young old people. But we do need to consider comorbidities and other risk factors such as polypharmacy. And when we're thinking about DMT specifically, should we be thinking about de-escalating the risk in our older patient group? And that might be giving them a lower risk therapy, so switching them from a more highly effective immunosuppressive therapy to something less risky, so to speak. Could we give it a lower dose? And by that, really probably the only practical example of that is to give maybe a B-cell therapy less often. Or should we discuss stopping treatment altogether with our older group of patients? And that does depend on the DMT. As I've said, some drugs come with a risk of rebound disease, and so we'd have to be very careful, which is where I think de-escalating treatment is probably the right thing to do. We haven't got any studies to support that yet, sort of exit strategies from highly effective therapies, but it seems sensible that in our older population we might step them onto something that comes with less risk but is still offering them some benefit as they move into older age. Next slide, please. That's me done. So back to you, Ruth. Thank you.
Thanks, Ray. Right, so thank you so much to the three speakers. We thought that, you know, there's so much information, it might be quite useful to actually go through a case study. So please do put your questions in the Q&A. If there's anything that you've been wondering at work, if there's anything particular about people that you've been looking after, just ask questions and we'll obviously have a look at those in a second. So suitably complex 58-year-old female. She works in IT. Before the pandemic, she did work at in the office. And since kind of all the changes where it was, you know, need to work from home, you know, she's evolved. So now she is actually mostly working from home. There's been some nudge from work that they would really like her to come back into the office, but she has deconditioned quite a bit and she's really struggling with her mobility. So she's finding that she's stumbling a bit. She's reporting short-term memory problems and low mood and, you know, quite severe fatigue. She has a very poor exercise routine. She's not really engaging with therapy. There's been referrals to physio and OT. She's been DNAing a couple of appointments, which is difficult because she is on Tecfidera. She was on, when she was diagnosed quite a while ago, she was on the interferons, and now she's on a Tecfidera for about the last 5 years. So she was diagnosed around 20 years ago. She is on quite a few medications. That's not just MS, that's kind of other comorbidities. She has diabetes, she is obese, and she did have menopausal symptoms. She was around 47, but she didn't go on HRT. There was a lot of nerves around anything like that at the time. And she didn't feel she knew that much about it, so she didn't. Her EDSS is 6, which, as we know, is she's sort of starting to need a walking aid. She's not really sure from conversations with her team whether there's an element of deconditioning or whether it is actually changes within her MS. So yeah, quite a lot going on for this lady. So I don't know whether I could open it up. Who would like to comment? Do you want to kick off, Wallace? What would you go about if this lady presented?
Well, I think the first thing to say is this is quite a common case history, isn't it? Quite a common story that we see all the time. I guess my first priority with her would be to try and get her engaging with the MS team again, both to safely monitor the drug that she's taking and then to start addressing some of these symptoms, which are probably partly MS related, partly age related. I guess the initial things I'd be thinking, you know, do we know that her MS is stable or not? When was the last time she had an MRI scan? She's got significant walking problems. Has she had a spinal cord MRI in the recent past? Tecfidera probably was the best choice for DMT for her, say in 2015 or 2016. Is it the best choice in 2024? So from a medical point of view, I would be wanting to review those issues. I'd be thinking about the medications she's on, whether there's anything that needs to be stopped that could be contributing, for example, to her weight. So a lot of our patients are taking high doses of gabapentin, for example, which can promote weight gain, or amitriptyline, which might also be having an impact on her memory. And then I'd be thinking about healthcare maintenance for her. You know, what's stopping her getting better control of her diabetes? Is she on treatment for osteoporosis to try and prevent fractures in the context of poor balance?
Thanks, Wallace. Someone's actually put a question about sort of having to reduce drugs gradually, and so for this lady, she's quite low risk. I guess it's about. So would you be thinking, particularly you mentioned about just having that discussion around the Tecfidera, were you thinking, what way were you thinking about de-escalating or just having a general conversation?
Well, I think that, you know, my view of this is that if you do autopsies on people with MS who are in their 70s, the brains are just full of inflammation. So inflammation is part of the illness from the start right through to the end. And I'd want her to be on the most effective DMT that's appropriate for her. And I think that hinges a bit on whether you think that she's developing obvious signs of progression, where you might be thinking saponamide, for example. I think that would take quite a lot of discussion and untangling in the clinic.
Perfect, thank you. I don't know if Ray or Michelle, do you want to chip in
Well, I
there
was
with
going to say,
anything?
yeah, I think this lady needs referring to Michelle's comprehensive assessment clinic for all the things. There's a lot going on for her, isn't there? So from my point of view, I would certainly, like Wallace has mentioned, want to exclude any drug causes of her stumbling and fatigue, for instance. You know, you want to make sure she's not on anything that's contributing to that, so that it is clearly her MS that's the issue. And we say when we talk to people about DMTs that diet and exercise is the drug we can't, you know, prescribe for them, but that we recommend for everyone to do alongside their DMT therapy is good diet and exercise. So this lady clearly needs some support with that before we decide what the right treatment is for her MS, I would say.
Rachel, can I ask on the issue of polypharmacy? I sort of wonder whose job is that?
Yeah.
Is it the GP? Is it community pharmacists? You know, should this be part of the kind of MS pharmacist kind of role to run like kind
Definitely.
of,
And I think as we go forward and we try and move away from DMT focused services, I think addressing the wider prescribing that goes on for MS patients sits with the MS pharmacists, certainly. So the feedback I get consistently from primary care is that they feel it's the specialist job to sort of adjust medicines that they perceive have been started or recommended by us. So particularly neuropathic and spasticity meds are very poorly managed, I feel, you know, because there's nobody really taking ownership. And the nice guidance for both those things is to add one thing at a time and take one away and add another one. And that, as we all know, in practice rarely happens. They get layered on top of each other. So I think if we could get better at taking a more comprehensive drug history and giving clearer advice to primary care about managing polypharmacy, that would be a huge step forward. Yeah.
I completely agree, Ray. And just quickly, that I know that some of the community teams can offer a structured medication review through a community pharmacy. I don't know if you want to comment on that or how much that service is being utilised.
Well, that service is actually also being withdrawn in a lot of in a lot of community pharmacies, unfortunately. So it's not something that's as easily accessed as there was a financial kind of incentive for community pharmacies to do that. That's no longer there, I believe. But I don't work in community pharmacy. But certainly GP practice pharmacies are probably very well placed to do that because they do medication reviews in GP practices. So I think we should be using our colleagues in primary care, also to try and engage them with that.
I have to say I've been actively asking for some structured medication review if there isn't time within clinic, but completely agree we need to look at it. Michelle, I just wondered if you wanted to comment on I know that a lot of patients that we're seeing, there is a huge amount of deconditioning, and from your background and experience, how difficult is that to work out what it is, and where do you go from that really with regards to management?
Yeah, I mean, there is a lot of deconditioning. I mean, I think with this lady, I would start with the drugs because, you know, talking about things like gabapentin, if someone's weak, that could actually be due to the drugs. So actually starting with the drugs and starting with the other health conditions probably is key. But this lady needs a proper sort out. And we've seen in COVID, haven't we, that people have worked more from home and have probably been going out and into work less. And so although that has been great for managing fatigue and all of the things that go around keeping people in work, actually it hasn't been great in terms of mental health, social isolation and keeping people active. And so it's a real balancing act. So I mean, if you just look at this case and think about those things that I went through, so she's got the comorbidities and polypharmacy. She's got a number of things related to that cycle of frailty that could be, I'm not saying she is frail, but that could feed into that cycle of making things worse. She's got things, the modifiable factors, and there are certainly mental health issues. So there's a lot to unpick. And I'm a physio, obviously, by background. And I can see that someone in the Q&As has commented about she needs a therapy review, and I think she does. She needs a holistic review, doesn't she, of what's going on and the appropriate referrals. So all of our services are different, all of our referral routes are different, but it sounds like she does need support to engage in her community and participate again, because she's becoming isolated. She's not engaging with the services. So that, as Wallace has said, is key. But she also needs actually a review of her mobility, her falls risk, her fatigue, and teasing out whether it is deconditioning or actual weakness.
And I think, you know, Michelle might disagree with me, but I think sometimes when you see someone put on a lot of weight, you know, particularly with telephone appointments and the pandemic, we saw people back for the first time face to face. It was a shocking. Some people put on a lot of weight. Actually, often, rather than being a lack of physical activity, actually it's been more about changing eating patterns in the context of, say, fatigue. And people can't, feel too tired to prepare a meal, so they're eating up a ready meal, or they're having kind of junk food. And often that can, or sometimes that can be a flag for mental health as well. Weight gain can be part of depression too. So I think thinking about that.
There's actually a lot of evidence now which says that weight gain actually is due to eating rather than lack of exercise. So yeah, that's absolutely right. I agree.
Yeah, thank you both. Joe, actually, who is an OT by background, is completely agreeing with you that obviously, someone like this lady needs to be seen by therapists. I think sometimes it is about that engagement, and that's really difficult with social isolation, the low mood, the cognitive changes. So I guess it is that very much a team approach. Someone else has asked, I'm not sure if we have time, we could maybe put something on the website, Wallace. I don't know if you want to quickly. There's the question around stopping treatments. That might take a little bit longer. Do you want to comment briefly, or?
Well, I think there's a question about how to stop IV therapies in people who are getting older. And I think we've got not many people on Ocrevus who are into their 70s, but we have got people that have been on Tysabri maybe for 15 years, and now they're in their late 60s or 70s. And I think Ray really nicely outlined some of the options in those patients. I think cladribine is the ideal choice in those patients, because you're hoping to bring about immune reconstitution. And I think the risks of kind of breakthrough relapses are lower at that age group. So I think cladribine, is the best way to discontinue Tysabri in an older adult, in my opinion. And Ocrevus in an older adult, I would say, or Kesimpta for that matter, if they've done 3 to 5 years of treatment and they're older or they're having complications, I think just stopping the treatment and observing with MRI is the right way to manage that.
Perfect, thanks, Wallace. And there's a question around drugs for overactive bladder. We do have a really good webinar from the Neurology Academy, so do have a look at that. It's really complex, and obviously it's very individual to the person. But the NICE guidance for MS does go through that in quite a bit of detail. So yeah, thank you very much for all of your questions.